Hello and welcome to part 2 of our first unit. We are going to be talking about our cholinergics and anticholinergics in this lecture today. So in our previous lecture, we talked a lot about the sympathetic nervous system and the effects of adrenergic drugs on the sympathetic nervous system. Well, we're going to switch gears here and we're going to flip to the parasympathetic nervous system. Again, this is our rest and digest nervous system. So in the following areas, you should see the following effects when the parasympathetic nervous system is stimulated. You should see pupil constriction. You should see the heart slowing down. So that's shown as negative inotropic effects, negative chronotropic effects, and negative dromotropic effects. As a reminder, inotropic is the forcibility or the force of contraction in the heart. So when we have a negative response to that, that essentially means that that force is slowed down and it's not as strong anymore. As far as that chronotropic effect, again, that's that time component. So we should see our heart rate or our pulses go down. And then we have that dromotropic effect, which is the electrical conductivity in the heart. We should see those impulses slow down as well. And the lungs, we should see bronchoconstriction and an increase in our gland secretions. For our urinary tract and our GI tract, we should see an increase in motility in the GI tract. This is also known as peristalsis. We should see an increase in our motility in the GI tract. We should see sphincter relaxation. You should see an increase in your gland secretions as well, because again, this is that rest and digest portion of this nervous system. We have our urinary tract in which our bladder sphincter is relaxed, so we're urinating more. Again, this is about that processing and that resting and digesting, and of course, eventually you would eliminate those things that you are processing. You have the skeletal muscle and the skin. There's not a lot of effects with that. But really, I want to pay attention to these glands, and you see an increase in salivation and lacrimation. Again, that's that rest and digest effects, and you also see an increase in that pancreatic activity. So again, the two branches of the autonomic nervous system includes the sympathetic nervous system and the parasympathetic nervous system. All about our cholinergics is focused on our parasympathetic nervous system. So just like we have adrenergic receptors, we have cholinergic receptors. So this is the parallel. For the parasympathetic nervous system, we are stimulating our cholinergic receptors, and we have two types that we'll discuss today. We have the nicotinic receptors, and we also have our muscarinic receptors, and the nicotinic is normally stimulated by nicotine or acetylcholine, and then we have our muscarinic receptor that is also stimulated by acetylcholine. So when we talk about our nicotinic receptors, those are our inotropic receptors, and again, when stimulated, this is a parasympathetic response. So the stimulation of these receptors should essentially activate the parasympathetic response as it relates to our heart. So we should see negative inotropic effects. We should see negative chronotropic effects. We should see negative dromotropic effects. So the mechanism by which this happens is that you have acetylcholine, which is our neurotransmitter, at play here. Again, the neurotransmitter is the chemical or drug substance, well, in this case, the chemical I'm speaking of, that helps with stimulating of these receptors. So just as epinephrine, norepinephrine, and dopamine stimulates the adrenergic receptors, cholinergic receptors are stimulated by acetylcholine. So we have acetylcholine that binds, and we have the diffusion of sodium and potassium, which results in the depolarization of the heart, which results in the voltage sodium channel activation, which ends up stimulating our action potential, which is a stimulatory effect. So when we have our nicotinic receptors, we do have eventual cell depolarization. When it comes to our muscarinic receptors, it's important to note that we have 5 different types of muscarinic receptors. And again, these receptors are stimulated by acetylcholine binding. But we do have 4 different types, and the types really depend heavily on the location. So M1 receptors, muscarinic 1 receptors, are normally located on your ganglia, exocrine glands, and the central nervous system. M2 are normally located on the heart, sweat glands, central nervous system. M3, you have your smooth muscles, which includes the blood vessels in the lungs, glands, eyes, central nervous system. M4, central nervous system and sweat glands. And then M5 is specifically to the central nervous system. So as you can see, all of the muscarinic receptors have some association with the central nervous system, and that's actually going to play a part in how the drugs play with our examples that we'll talk about. So here we have our table on how the cholinergic drugs or cholinergic agonists stimulate the parasympathetic nervous system, and these are the effects on the different areas on the body. As it relates to our muscarinic receptors in the lungs, it does increase those secretions and bronchoconstriction, the closing of those vessels. You have in the cardiovascular system, your blood vessels are dilated, your heart rate is slowed, your blood pressure is decreased. In the eyes, you have your pupil constriction or miosis, or decreased accommodation is another way of saying that. You have gastrointestinal tone increased, your motility is increased, and your sphincter is relaxed. Again, this is that processing portion of the parasympathetic rest and digest. You are digesting. With the genitourinary tract, again, you have your increased tone, increased motility, and your sphincter is relaxed in your GU system. As far as your secretions, again, you have increased intestinal, lacrimal, salivary, and sweat gland secretion. So the thing about the parasympathetic nervous system is that the drugs are known as parasympathomimetics, or they are drugs that mimic the effects of acetylcholine. They're also known as cholinergic agonists. So anytime you hear any of those three terms, cholinergic drugs, parasympathomimetics, or cholinergic agonists, they are drugs that stimulate just very similar to acetylcholine in the muscarinic and the nicotinic receptors. So when we talk about acetylcholine, it's important to talk about the enzyme that breaks down acetylcholine. So you have levels of acetylcholinesterase, and anytime we have the A's at the end of a word, that generally means an enzyme. And these enzymes are ones that break down acetylcholine. So again, this is also known as a cholinesterase. You do have two different types. You have the reversible inhibitors and irreversible inhibitors. When you talk about the reversible cholinesterase inhibitors, they bind to cholinesterase for a short period of time, whereas irreversible cholinesterase, they have a long duration, or they stay for a while. So if this is the case, the body has to generate new cholinesterase enzymes to override the effects of those irreversible drugs. So just remember that acetylcholinesterase, the enzyme, is the one that is responsible for breaking down acetylcholine. So the next section we'll talk about our indications for cholinergic agonists. So you have two different subtypes of cholinergic agonists. You have direct acting cholinergic agonist and indirect acting cholinergic agonist. That's a lot to say, but just follow us here. Direct acting cholinergic agonists, or cholinergic stimulators, are parasympathomimetics. Direct acting parasympathomimetics, it helps us treat two different conditions, one of which is in the eyes, and that's called glaucoma. And as we discussed in our previous lecture, glaucoma is characterized by increased intraocular pressure, or in other words, hypertension in the eyes, high pressures in the eyes. I've mentioned that our eyes are vasculated, and it's important to note that because there's this vasculature in our eyes, we do have the potential to have hypertensive issues in our eyes. Again, this is known as increased intraocular pressure. So in the case of glaucoma, we do use cholinergics because it does help with pupillary constriction, which ultimately decreases intraocular pressure in the eyes. So you do want to use a direct acting cholinergic agent for that. As far as urinary tension is concerned. Urinary retention is characterized by the body physically holding on to the urine. You're unable to pee or urinate when you have urinary retention. So with that, you need a medication. And again, this is what cholinergics do. They help you rest and digest and even process. So it helps with urinary retention because it's forcing the detrusor muscles in the bladder to contract, which helps you squeeze out the pee that you do not need to have in you. So again, direct acting cholinergics particularly are used for glaucoma and urinary retention. We do have different examples of that. We have carbachol, pilocarpine, and ecothiopate, and these again are used to decrease our intraocular pressure, whereas bethanchol is used for urinary retention. As far as our indirect acting drugs are concerned, again, these are more stimulated by acetylcholinesterase inhibitors. And when we talk about that, this is something that helps to increase the levels of acetylcholine in the body. So it's indirect in that it's inhibiting the enzyme acetylcholinesterase from being active in order to help increase those acetylcholine levels and thus helping stimulate the parasympathetic response. Now, these indirect acting drugs are normally used for Alzheimer's disease or myasthenia gravis. So it normally helps to have a cholinesterase inhibitor, indirect acting cholinergic drug, because it really Alzheimer's is related to a decrease in acetylcholine levels in the brain. So this is all central nervous system related. So it has been shown that although you can't cure Alzheimer's disease, you can help mitigate the effects of Alzheimer's disease by using the acetylcholinesterase inhibitor. And such is the case in myasthenia gravis. It is helping you to increase those acetylcholine levels to help with those adverse effects that are associated with myasthenia gravis. So here are our drug profiles or our selected examples for our cholinergics or our cholinergic agonists, parasympathomimetics. Um, the first one we'll talk about is bethanchol, and I've already kind of talked about this in our previous slides, but this is the one that we use for urinary retention. So again, our body is physically unable to urinate, so we use a cholinergic agonist, direct acting particularly, to help treat urinary retention. When we talk about neurogenic apnea of the bladder, that means that it's just not working. The muscle tone is less and it's unable to excrete the urine. So this direct acting cholinergic bethanchol helps with that, and it helps with the excretion of the urine. The next one is a cholinesterase inhibitor. This is also known as an indirect acting cholinergic. So when we talk about this one, the donezepil, it helps by increasing the levels of acetylcholine by inhibiting the enzyme that breaks down acetylcholine. So we talked about what those enzymes were. That is called acetylcholinesterase. It is an enzyme that breaks down acetylcholine. So Aricept or donepezil, it inhibits the enzyme that essentially breaks down acetylcholine. So again, we do increase our levels of acetylcholine as a result of this. As I've mentioned in our previous slides, Alzheimer's disease is heavily associated with decreased acetylcholine levels. So if we inhibit that enzyme that thus decreases those acetylcholine levels, we inherently increase those acetylcholine levels. So again, it does help in Alzheimer's disease. Now, a patient teaching point in this is to make sure they know it does not cure Alzheimer's. It's not a direct fix-all for Alzheimer's, but it does help to mitigate or decrease those symptoms associated with Alzheimer's disease. So we do use it in mild to moderate Alzheimer's. As far as pyristigmine, this is a compound that we use to treat myasthenia gravis. And if you know anything about myasthenia gravis, it's characterized as fatigue and muscle weakness due to your impaired muscle contractions. And that is an issue that is associated with the brain and your central nervous system. So this is also a acetylcholine inhibitor. uh, acetylcholinesterase inhibitor, which would help further increase acetylcholine, which would help improve the muscle strength. And again, it does help relieve the symptoms of myasthenia gravis. The thing about myasthenia gravis is that it is a autoimmune disorder, and it is where the body is destroying communication between the central nervous system and the muscles. This is why we do see that weakness in the skeletal muscles. So it does affect the voluntary muscles of the body, particularly those in the throat, limbs, mouth, and eyes. So we have to be very careful with individuals with myasthenia gravis. But again, when you administer mestinon paracetamine, it helps with those symptoms. Here are our contraindications for administering a cholinergic agonist. And again, these are areas that we don't want to give people this medication because it'll further exacerbate the conditions that they already have. In the sense of bradycardia, well, cholinergic agonists help with bradycardia. They're structured to help with the rest and digest system. So if we give a cholinergic to someone that's already bradycardic, we can see even further slowed heart rates, and we can send someone into cardiac arrest with that. Asthma, which is contraindicated because of the bronchoconstriction and bronchospasm. Individuals that have asthma, this would further exacerbate those symptoms, which would cause shortness of breath and things along those lines. It's also contraindicated for individuals with COPD as well for the same reason. It would further exacerbate bronchospasms and shortness of breath in those individuals. You want to avoid giving a cholinergic to those that have an intestinal or urinary obstruction, because if you stimulate peristalsis, or if you stimulate the urinary bladder to do its job to process, and there's an obstruction, it could lead to a backup, and again, that could cause serious adverse effects. You want to avoid this in pregnancy or breastfeeding. You want to avoid these medications in those that have arrhythmias or dysrhythmias, especially those that are bradycardic or also have a AV block or a heart block. You want to avoid this in individuals that have severe hepatic or renal impairment, and that has a lot to do with the excretion and the metabolism of the cholinergics. You also want to avoid this in individuals that have coronary artery disease, epilepsy, or history of seizures. So again, just make sure you familiarize yourself with these contraindications as it relates to cholinergic agonist. So here are our side effects. Under cholinergic side effects, we have miosis, blurred vision, headaches, dizziness, drowsiness. In our airways, we have bronchoconstriction, shortness of breath, and persistent cough. Cardiovascular, you have that bradycardia, heart block, hypotension, cardiac arrest. GI tract, you have nausea, vomiting, cramps, diarrhea. You see it increase in salivation or involuntary defecation and GI bleeds. And in the urinary tract, you have a more sense of urgency to go to the bathroom. One thing that you want to watch out for is cholinergic toxicity. And what this is the same concept of having too much of a drug. Too much of anything can cause poisonous or toxic effects. And in this case, we're talking about cholinergics and specifically cholinergic toxicity. So if you receive too much acetylcholine medication, something that helps to stimulate acetylcholine or blocks the acetylcholinesterase enzyme that will thus increase acetylcholine levels, it can result in too much acetylcholine at the neuromuscular junctures. So this is known as our cholinergic crisis. So you want to make sure you report these signs and symptoms. It's diaphoresis and diarrhea. You may have urinary frequency, miosis, bronchospasm, emesis, that's vomiting or nausea, lacrimation or salivation. And then if these effects are considered severe enough by the healthcare provider, you want to be prepared to administer the antidote. The antidote to cholinergic toxicity is atropine. it is atropine. Atropine is our cholinergic antagonist. When we talk about antagonists, those are things that block the actions of cholinergics. So an antagonist, this atropine is used to help with that. So again, you'll see salivation, lacrimation, urinary incontinence, diarrhea, GI cramps, and emesis, but this could ultimately lead to a cholinergic crisis. And if the symptoms are considered severe enough, you will have to administer atropine as the antidote to your cholinergics. So next we'll talk about our nursing process. And again, this is our assessment piece in which we will take care of our patients. So again, anytime we administer drugs, we do need to assess our vital signs and document particularly what the baselines are for the vital signs. So you look at your oxygenation, you want to look at pulse, you want to look at all of your vital signs to make sure that you're administering these medications in the appropriate way. As we know, parasympathomimetics affects several body systems, so you have to have this holistic approach with your physical assessment and vital signs in order to make an informed decision and to be able to report to the healthcare provider any abnormal symptoms. So we have our human needs statement or our nursing diagnosis, and here we have altered oxygenation, decreased cardiac output related to adverse cardiovascular effects of hypotension and bradycardia, as evidenced by what you're seeing in the clinical environment. And that can be anything. You can see dizziness, you can see diaphoresis, you can see anxiety, you can see all kinds of things as it relates to these nursing diagnoses. As far as planning, these are our outcomes identification. This is things that we are planning to actually do to the patient in order to make sure that they are safe and having effective treatment. You want to make sure the patient maintains oxygenation. You want to make sure they maintain maximum cardiac output. You want to make sure that you are, as the nurse, conducting safe administration and make sure they are conducting safe administration outside of the clinical environment by patient teaching. You want to ensure that you monitor blood pressure and pulse at a frequent interval or as prescribed by the provider. You want to make sure you report any adverse effects of dizziness, fainting, excess fatigue, and lightheadedness. In treating our conditions, we talked about two different ones. That was myasthenia gravis and Alzheimer's disease. You want to make sure that you give the medication about 30 minutes before meals in the case of myasthenia gravis to allow for the onset and action of therapeutic effects such as decreased dysphagia or decreased difficulty in swallowing. You also want to be prepared to administer the atropine as an antidote to the cholinergic overdose. You want to make sure that you have these medications readily available and give per the prescriber's order. As far as your evaluation piece, you want to ensure that you monitor patients for therapeutic effects. So in myasthenia gravis, you want to ensure that there's a decrease in that skeletal muscle weakness and that tiredness and the incontrollability of their extremities. You want to make sure that if you're using Bethancoll, for example, post-operative for the urinary retention, you want to ensure that there is that the patient does urinate, or you do hear an increase in bowel sounds or flatulence, or other words, make sure that there's peristalsis happening in the clinical environment. So again, the nursing process is very important when it comes to the administration of our cholinergics, because if we see any abnormalities, we'll be able to assess that and then act accordingly. So we've reached our final chapter in our lecture today. We will be talking about anticholinergics. So the main thing to remember is that anytime we're talking about cholinergics, this is talking about the parasympathetic nervous system. So we're going to have a double negative here, and we are talking about anticholinergics. So really what we're saying is that anticholinergic drugs actually mimic the effects of the sympathetic nervous system because of what it's inhibiting. And we'll talk a lot about that in our next slides. Here's your reminder slide regarding the parasympathetic nervous system. Again, this is all about resting and digesting. So a special attention to the GI tract and the GU tract, we see that there is increased activity across both receptors, the muscarinic and the nicotinic receptors. We do see a slowing down in the cardiovascular system, particularly in the heart rate, and your blood pressure is decreased, and you do see vasodilation as it relates to the muscarinic receptors and the nicotinic receptors. At certain levels, you do see increases in these areas, but we'll talk a little bit about that later. So again, here's another slide regarding acetylcholine. Anytime we talk about our cholinergic drugs, we're talking about the neurotransmitter of acetylcholine. And we do have two different types of nervous systems. You have the parasympathetic and the sympathetic. Again, we are focusing on the parasympathetic nervous system, and that is heavily associated with the neurotransmitter acetylcholine. So again, we look at the rest and digest here. We have a decrease in heart rate. We have a decrease in body energy use because our body is indeed processing. On the right here, we have several different types of drugs here, are anticholinergic drugs, and I want you to pay special attention to atropine. We talked about atropine as an antidote to cholinergic toxicity because it is a cholinergic antagonist or anticholinergic. So atropine is one of our first line cholinergic antagonists, are really an antidote because of its effects on the body system. Again, when we have an anticholinergic effect, we're really mimicking or stimulating the effects of what would be similar to the sympathetic nervous system. So our anticholinergic effects are hot as a hare, dry as a bone, blind as a bat, red as a beet, and mad as a hatter. You're hot to the point where you do get dry, dehydrated. You're burning up. You're blind. You can't really see anything. You're red because of how hot you are. And you're mad as a hatter, and you're starting to experience anxiety. So again, these are areas where you have anticholinergic effects, and they do mimic what you would see in the sympathetic nervous system stimulation. So here are our reminders of our cholinergic receptors. As we've discussed earlier in this lecture, we have our nicotinic receptors and we have our muscarinic receptors. And with our muscarinic receptors, we have 5 different types. Really, when we have an anticholinergic, they are competing with acetylcholine, the neurotransmitter acetylcholine, to bind at the cholinergic receptor at the muscarinic site. So it's a competitive mechanism where it tries to bind at that site prior to acetylcholine binding at that site. So again, it is a competitive cholinergic antagonist. Another way to discuss anticholinergic drugs is to say that these anticholinergic drugs cause the opposite effect to those of cholinergics. So it's important to note with the cholinergic effects, what happens when there's a small dose and what happens when there's a large dose, particularly when we talk about the cardiovascular system and the central nervous system. So at small doses, when we have a cholinergic blocker or a cholinergic antagonist or anticholinergic, we have small doses that decrease the heart rate, which is the expected response. But at large doses, very large doses, we see an increase in heart rate. With the central nervous system, at small doses, we see a decrease in muscle rigidity and tremors for the central nervous system. But in large doses, we see drowsiness, disorientation, and hallucinations. So we say all of that to say this. Normally, you want to look at how much of a drug that you're getting, because if you're seeing effects that are potentially harmful to the patient, you want to look at your doses and be prepared maybe to even administer an antidote for this as well. Now, don't get this confused with atropine. Atropine is actually an anticholinergic that is an antidote for cholinergic crisis, but sometimes we do get too much of an anticholinergic as well, and we have to do the reverse thing and give a cholinergic to help antagonize the effects of an anticholinergic, okay? So just make sure you review this slide and look at the opposite effects of those dealing with cholinergics. So again, we are talking about anticholinergic drugs, and our drug of choice is atropine. So we'll talk about atropine as it relates to symptomatic bradycardia. Now, as I've stated before, there are bradycardic symptoms, or there are people that exist with bradycardia that have no symptoms at all. But when we have those that start exhibiting those symptoms, they're dizzy, tired, they're in a coma, fatigued. They are having low blood pressures as it relates to bradycardia, and we're talking about symptomatically low, like 70s over 50s, 80s over 40s, things like that. This is symptomatic bradycardia, and we do have to treat with the anticholinergic. So again, you have to have signs that you require treatment for. So that means that they're hemodynamically unstable. So if this is the issue, if you want to use an anticholinergic, our first line is IV atropine. And then on this slide, you may actually recognize a couple of these other drugs. You see dopamine or epinephrine. Dopamine and epinephrine are adrenergics, but remember what we discussed earlier in this slide. Anticholinergics actually mimic the effects of the sympathetic nervous system in the same light that dopamine and epinephrine does. So it makes sense as to why we would give atropine as our first line for symptomatic bradycardia, and then we may even give dopamine or epinephrine. So if bradycardia persists despite intervention from the IV atropine, dopamine, or epinephrine, we may do something called pacing. And pacing is where we basically put a catheter that emits an impulse through a vein to the heart to set the heart rate. So you can do transvenous pacing or you can do external pacing. You do this either way. But basically, this requires, or it tells us that this individual may need a pacemaker. And if you know anything about a pacemaker, that helps to stimulate heart rate electrically. It's literally a device that's inserted into an individual permanently that overtakes the SA node's job of being the pacemaker, and it helps pace the heart and helps it beat and contract. So when you talk about your anticholinergics, you want to think symptomatic bradycardia because these are the steps that we take in order to help treat symptomatic bradycardia. Again, do not forget those words, symptomatic bradycardia. If you are unstable hemodynamically and you have bradycardia that exists with that, that's when you treat with an anticholinergic called atropine. And then you may see individuals get two different types of adrenergics, either dopamine or epinephrine, depending on their clinical condition. These also help to treat tardive dyskinesia, which is associated with Parkinson's disease. This is involuntary rhythmic movement within the body. You may have dystonia, which is muscle spasms of the face, neck, back, jaws, things like that. And you also want to use this for supportive care and symptom management without treating the disease. So these are several different indications that you should know about as it relates to anticholinergics. So you can have anticholinergic toxidrome, and this is normally characterized as some of our adverse effects here. So again, you have hot as a hair. This is anhydrosis. This is without water with temperature elevation. That's speaking to some dehydration there. You are blind as a bat. So that's mydriasis. So you have that pupil dilation or dilated pupils, so you can't necessarily see that well. You are mad as a hatter, so you're confused, delirium, you have hallucinations, red as a beet. There's vasodilation causing skin hyperemia or redness in the skin. Erythemia is another way to say that. You are full as a flask, you have urinary retention, and you're dry as a bone. So your mucosa, normally your mucosas are wet, those end up being dry, so you have dry mucosas. So as far as your muscarinic receptors, you do have these different side effects that you should look out for. Again, if it's strictly related to the muscarinic receptors, you may see dry mouth, blurred vision, urinary retention, and constipation. So again, just familiarize yourself with this slide and make sure you understand and read it very well. Here are the selected drug profiles for the anticholinergics. We've talked a lot about atropine, or in other words, atropine, and it is an anticholinergic. It increases heart rate. It is used to treat symptomatic bradycardia and also ventricular asystole, which means that the heart has completely stopped beating. Atropine is an antidote for anticholinesterase inhibitor toxicity, or cholinesterase or cholinergic toxicity is another way of saying that, or poisoning. You have scopolamide, and you normally use this for the prevention of motion sickness, and it also works by correcting the imbalance between acetylcholine and norepinephrine in the higher centers in the brain, and particularly the vomiting center. And then you have oxybutynin, and this is an antimuscarinic drug that is used for the treatment of overactive bladder. So that means you're urinating too much and you need something to help you stop urinating as much. So as far as your contraindications, you want to avoid using these medications in people with known drug allergies, urinary or gastric retention, and uncontrolled angle closure glaucoma or hypertension. As always, we learn about our drugs because we want to complete the nursing process. So again, you're going to do a full physical head-to-toe assessment. You're going to get your vital signs on your patients, and knowing the way these drugs work related to the physical assessment piece that you have for your patients will end up being a more safe environment for not only the patient, but also it'll help protect you as the nurse because of your assessment piece. You have your nursing diagnoses, and this is consider altered GI elimination, constipation related to adverse effects of cholinergic blocking drugs, as evidenced by whatever you see in the clinical environment that proves said issues or related to issues. As far as planning, you have outcomes identification. So these are things that you want to focus on in the nursing process. So this is patient experiences or regains normal bowel patterns through the increase of fluids. Patient demonstrates adequate knowledge about the use of specific medications, adverse effects, and appropriate dosing at home. As far as implementation, this is what the nurse is actually doing in the clinical environment to help with said issues that the patient is experiencing according to the nursing diagnosis. So you want to have a preventative focus, and you want to make sure that you implement effective use of cholinergic blocking or cholinergic antagonistic drugs, especially with regard to patient teaching. And you want to make sure how you teach the patient is in terms that they can understand. That way, when they're outside of the clinical environment, they'll be able to still be safe and have safe practices with these medications. And as far as evaluation, of course, you're looking to see if there's a decrease in the issues that caused you to have to use the medications. So you should see effective therapy with the administration of these medications. If not, then you should reassess and see what else could be causing these potential issues. Thank you for listening, and if you have any questions, please feel free to reach out to both of your instructors. We'll be more than happy to assist you. Thank you and have a great day.